Introduction to Nursing Concepts, Oxygenation, Part 3. This is Martha Olson. COPD is chronic obstructive pulmonary disease. When we look at a patient with COPD, they oftentimes are functioning with a lower oxygen saturation level than the average person, and this is their normal. This is a chronic respiratory condition, and the CO2 levels then help them, or is how they survive. And by administering excessive oxygen for them, it actually causes more hypoventilation. As a new grad, I remember going in and checking the O2 sat on a patient, and it would be 90 or 91%, and your first instinct is to go and turn up the oxygen to improve that. But remember, for that patient with COPD, that is their drive or stimulus to remember to breathe, is that CO2 level. So as we look at our assessment of oxygenation, the subjective is what they say. I feel short of breath. And you may observe with the objective data that they are dyspneic. They have nasal flaring retractions. They become very short of breath with activity or ambulation. Our signs and symptoms of respiratory function are not only the chest and the chest wall, it's their color, it's their nail blanching, it's the periphery also out to the fingers and toes, looking, is that oxygen getting to where it needs to go to keep the cells alive? So there is quite a bit of assessment that goes with respiratory. As we look at that assessment, then to inspect is to look. You look at how easy or even the patient is breathing. Is that chest wall rising symmetrically or evenly? A patient with an injury, especially a motor vehicle accident where their chest hits the steering wheel, oftentimes you will have a lung that is not functioning and the chest wall will not rise evenly. Palpation is to feel, and you can actually put your hands on the patient's chest to feel. Are they breathing evenly? You can feel, is there broken ribs? Many things that you can feel with palpation, including a thing called crepitus, which is an air leak from the lung, and the air gets trapped kind of between the skin and that lung. Percussion is to tap, and as I discussed in class, you can percuss a lung to see if it's a high-pitched percussion, it's air, and if it's low-pitched, it's either full of mucus, fluid, or possibly even like a cancer or a tumor. And then auscultation is to listen. That is the act of either listening from the doorway. Sometimes I can hear a patient with croup where they have that high-pitched breathing, or with your stethoscope, when you put the stethoscope on the chest, and remember, for your auscultation, you do not want to put the stethoscope over a shirt, a t-shirt, a gown. You want to put it, the stethoscope, to the skin, or you will hear things that are not truly there. It's the rustling of that, perhaps, gown through that stethoscope. As we look at review, table 42 and 43 would be good to review. Look at the lung sounds in chapter 33. Know the difference between crackles and rales. That's fluid in the lungs, usually in the dependent lobes, because fluid would go with gravity. Rhonchi and a wheeze. That is where the trachea and the bronchi are narrowed, and your wheezing, remember, is kind of that high-pitched, squeaky. A patient with asthma with narrow airways would have kind of a wheeze to it. It can be an inspiratory wheeze where they breathe in and you hear it wheezing. It could be an expiratory wheeze where they breathe out or let the air out and you hear wheezing. Or it could be inspiratory, expiratory, where it's very serious, and it's both. Looking at our subjective and objective data, then, subjective is what they say. I feel short of breath. I'm having chest pain. I feel tired when I walk. They complain of maybe heaviness, or they describe it as a shortness of breath. Your objective is listening to those lung sounds, checking your pulse oximetry on the finger, looking at what kind of sputum they are expectorating, or are they coughing? Is it an occasional cough? Is it a dry, hacky cough? All of those things used to describe very carefully in your documentation. Remember that if you are getting a sputum culture or a sputum specimen, it needs to go in a sterile cup for analysis. It needs to be labeled with the patient's name, the date and time that it was collected, put in that sterile cup. It's the little cup with the orange top, and then taken directly to lab. As we look at our signs and symptoms of the respiratory system, we look at orthopnea, or the patient has to sit upright in order to breathe. Cyanosis is that discoloration, usually kind of a purple or bluish color. If it's central cyanosis, it's to the mouth and to the mucous membranes and under the eyes, in the membranes of the eye. Very serious when it's central cyanosis. Acrocyanosis is a term we use in newborn babies, and they have just a little bit of blue to their fingertips as they're transitioning from the utero into life and where they're breathing on their own. We watch those babies very carefully. Cyanosis to the periphery in an adult is serious. We need to consider what is causing that. And sometimes with your patient on hospice that is dying, the cyanosis is one of those signs where you start thinking, we need to make sure the family's here and the circulation is slowing down in those patients. Chest pain is a sign of respiratory function because if the myocardium is not getting oxygenated blood, it will result in the irritation of those tissues. The myocardial tissues will start having chest pain or causing chest pain to let you know we're not getting oxygenated. Shortness of breath, do not ever use the abbreviation SOB because it can be misconstrued as something else. So we want to get in the habit of using dyspnea. The important part of thinking about charting or looking for dyspnea is it at rest or with exertion? Exertion means walking to the bathroom, walking in the hall, doing an activity, even a bath on some of our respiratory patients is exertion enough that they become very short of breath or dyspneic. A patient at rest that's dyspneic is very serious. Any patient that is just sitting in bed or sitting in the chair, working really hard to breathe, to me that's a very serious condition that we need to look into interventions. What are we doing? How is the patient doing? And then your sputum production, chart what color. Is it thick or thin? Is it watery? Hemoptysis, hemo is bloody, and so hemoptysis is kind of a bloody sputum. It could be a bloody sputum if they have cancer, and that's sometimes what gets people into the doctor to have that evaluated. But sometimes after a breathing treatment or after an injury, a real hard coughing, sometimes patients will normally have just a little bit of bloody sputum. So it has to be documented and evaluated. Watch to see, is it happening again or is this just a one-time occurrence? The cough, again, make sure you chart. Is it kind of a dry, hacky cough? Is it a moist, productive cough? Is it frequent or infrequent? And then are they using accessory muscles? And are you noting nasal flaring where those nares are enlarging to let more air in as a compensatory mechanism? The retractions are on the chest. Those would be noted right under the ribs where it kind of sucks in as that person is trying to get some breath. Orthopnea is definitely a term I would put a star by. I would want to know that. They have to sit up or stand up to breathe. When you think about having a cold, where do you sleep when you can't breathe? You go out and sit in the easy chair in the living room. Be sure to review your Potter and Perry book on the adventitious lung sounds, crackles, rhonchi, wheezing, so that you can identify, is it moisture in there? Is it narrowing that's causing a high-pitched sound or a wheezing? As we look at the respiratory patterns then, these are terms we use in respiration. EU is normal. So eupnea is a normal breathing. 12 to 20 times a minute. It's not, they're not working very hard to breathe. Tachypnea is breathing too fast. Tachy is fast and brady is slow. So tachycardia would be more than 20 times per minute in an adult. Children have different parameters. Bradypnea then is less than 12 times per minute. Apnea, A is without. Apnea is not breathing at all, and as you look at all of these respiratory patterns that are listed in the bulleted form here on this PowerPoint slide, get in the habit of thinking, which one is the most serious? Which patient would I go see first? And on this slide, your apnea is going to be the one that you say, go see them first because they are not breathing. And being CPR certified, you would then start your CPR, open the airway, assess for breathing and start your rescue breathing on that patient. Hyperpnea is breathing too fast, same as tachypnea. Kussmaul is often seen in your patient that has a diabetic reaction, a high blood sugar, and a Kussmaul is a very deep breathing, and it's because the body is trying to compensate with the pH level and it's blowing off more carbon dioxide, trying to maintain homeostasis. Shane Stokes then is kind of on and off, on and off, and those are the patients when I am caring for a hospice patient that I note I go in the room and they won't have been breathing for 20 seconds, and then all of a sudden they will start breathing again. Or the family will call you down to the room and say, I think mom's gone, she hasn't been breathing, and then all of a sudden she starts breathing, and it can be very scary for that family. And I always tell patients, families, this is kind of an expectation, and it's just the body's way of kind of telling us that the end is getting near. But with that education, the families kind of anticipate that, it'll be okay. When we look at BIATS, it's just an abnormal or irregular breathing for a variety of reasons. It needs to be evaluated, but they are breathing, so that's a good thing. And then when we look at the last one, I've never used that really in the nursing that I've done through the years, but the definition of apneuristic then is a free air with a collapsed lung. So don't expect that last one on the test because it's not one I see often, but put a star on these because these are free game for the test. As we look at our lab values that go with our assessment for this unit, a CBC, complete blood count, is looking at that white blood cell. Do they have an infection that goes with pneumonia? Our cardiac enzymes are going to go with that person that's possibly having a myocardial infarction or a heart attack. And we have to rule out, is there problems with that heart? Our electrolytes are very important to know for this unit because electrolytes help to keep balance in the body, and they help control the regularity of the heart. Is it in a nice PQRST or a nice rhythm? And then cholesterol adds to atherosclerosis and hardening of the arteries, and it makes, circulation much more difficult. As we look at a normal oxygen saturation, I would also add this to my lab values. A normal O2 saturation, or O2 sat, is 95 to 100%. If it's below 92%, we need to assess. We need to figure out what's going on, and we need to apply oxygen if it's appropriate. So part of our critical thinking is this cute little gal that says, if she has dark skin, how do you assess for cyanosis, or that blueness? And the answer for that is looking in the mucous membranes. Pull the lower lip down and look at that inside mucosal membrane, the gums. Look in the eye, the membrane of the eye. Is it pink? Or is it a cyanosis? And those are things that you can do if the person is of a background that has darker skin. As we look at our nursing diagnosis that go with this unit, ineffective airway clearance, impaired gas exchange, and ineffective breathing patterns are all part of the nursing diagnosis. Ineffective airway clearance is usually from things like mucus, or something is occluding their ability to have normal oxygenation. As we look at the second one, impaired gas exchange, it could be related to like a COPD from alveoli damage, those little grape-like clusters that are not functioning or not healthy. And then ineffective breathing patterns. Maybe they're breathing too fast or too slow, or they're a hospice patient that's having the Shane Stokes respirations. Again, put your numbers beside these, with your impaired gas exchange being number one. That means you're not getting oxygen to the tissues. And secondly would probably be your ineffective airway clearance. And the last one of priority would be the breathing pattern. In our planning phase of the nursing process, we look at our outcomes. Our ABCs, airway, breathing, and circulation, are our priority. The most important goal is to maintain a patent airway, and also improving their tolerance and their exercise. We want to look at, what is going on with this person that we can prevent any serious outcomes to their oxygenation status. In community health, part of our planning would be promoting exercise, getting people to quit smoking, living in a healthy environment, checking for radon in the house. Many things go in that planning phase depending on what type of nursing we do. Our implementation phase is the interventions related to airway management. Is it giving a breathing treatment? Is it applying oxygen? Is it promoting deep inspiration and prevention of pneumonia by going in every hour and making sure that the patient uses the incentive spirometer? So there are many things that a nurse can do within our scope of practice that helps